Dear students, welcome to Racing Against Time for Students in Pathology and our continuation of GAT shall be there. The topic for the day is ulcers of the intestine and the significance is given within the enclosure. And these are the subheadings we shall be dealing with. Always think of the subheadings will take you to the answer. In this picture, I am finding multiple irregular confluent shallow ulcers, which is classical of a condition called as Clostridium difficile. Generally, we are asked what are the causes and the types of intestinal ulcers. They can be divided under the following subheadings. One is infective. One cause we have already mentioned, the Clostridium difficile. The others are tuberculosis, typhoid, and amoebic ulcers. These three have got specific pathological, morphological, and microscopic features, and hence they will be repeatedly asked as questions. Also, the other causes for intestinal ulcers come under inflammatory, and these are ulcerative colitis and Crohn's disease. This will be dealt with in detail in a separate topic, but we shall be focusing on the ulcers alone. Malignancy means carcinoma of the colon. So these are the causes of the ulcers. Please note it down. We start with Crohn's disease. It is one of the inflammatory bowel diseases. And in this particular picture, I am finding that there is a normal mucosa and then there is a diseased mucosa also. In this diseased mucosa, I am finding multiple pebble-like structures called as cobblestone appearance. And in between, there is an area of congestion, and these are slender, snake-like, and they are called as serpentine ulcers. This is involving the entire thickness of the wall, as a result of which it becomes narrowed down and it develops a lead pipe-like rigidity. So clinically, it is a lead pipe rigidity that we get in a Crohn's disease, and radiologically you find because of the narrowed lumen, there is a string sign that is seen. Apart from this, there can be multiple skip lesions. Here itself, I am finding a normal area and an abnormal area. And histologically, the granuloma is the hallmark. So this is a microscopic picture of the Crohn's disease. This is a normal intestine that I am seeing and a well circumscribed granuloma. There are no areas of caseation or necrosis that is seen. As I mentioned earlier, there are two types of this inflammatory bowel diseases, ulcerative colitis and Crohn's disease. Let us try to recollect what are there in this slide. The site of origin, these are the subheadings. Always we should be recollecting the subheadings. Site of origin, in ulcerative colitis it is rectum, and in Crohn's it is the terminal ileum. Patterns, it is continuous in ulcerative and there are skip lesions in Crohn's. Thickness of the inflammation is superficial, limited to the mucosa and submucosa and ulcerative colitis, whereas the entire wall is involved in Crohn's. It is called as transmural inflammation. The lesions are pseudopolyps and a cobblestone appearance that we had seen earlier. Radiologically, nothing specific in ulcerative colitis, whereas in Crohn's disease, owing to the lead pipe rigidity, there is a narrowing and a string sign that is diagnosed. The complications in ulcerative colitis include toxic megacolon, and the malignancy is 3 times more common than Crohn's. In Crohn's, there can be fistula formation, and malignancy is there, but 1/3 the frequency. Histologically, there is a classical cryptapsis in ulcerative colitis. Without this, we are not supposed to make a diagnosis, and granuloma is the hallmark of Crohn's disease. Please by heart this tabular column. Going to the next condition, the ulcerative colitis. Here also I am finding multiple polypoid lesions. They are all not true polyps, but with ulceration I find that there is an overhanging adjoining mucosa. And this leads to what is called as a pseudopolypoid appearance. They are not true polyps but pseudopolyps. What are the other features that we can see? It is a continuous lesion, not a skip lesion. There is thinning of the wall, there is no thickening. Backwash ileitis. As the name implies, it is a colonic disorder, but sometimes you find it can involve the terminal ileum and it is called as backwash ileitis. And sometimes you find in spite of the ulceration, the mucosa can be connected together and this is called as mucosal bridge. Malignancy is very common, 3 times more common here than the Crohn's disease. Crypt abscess is the hallmark. If you are asked one question about ulcerative colitis, mention the crypt abscess. This is the colonic crypt and in which I am finding aggregate of neutrophils which is also infiltrating the wall, a classical picture of a crypt abscess in ulcerative colitis. There will be distortion of the crypt. Again, there will be branching, etc., which can be seen, which is distortion. Perforation of the intestine and electrolyte imbalance are common features of ulcerative colitis. Please by heart this particular list, it is worth reading. And this is a diagrammatic representation. The credit goes to these people. So the normal colon over here, and these are the goblet cells, and these are the crypts. Here what happens is within the crypt there is a collection of the inflammatory cells, neutrophils, and it is also involving the pericryptal area, and this is called the crypt abscess. The third lesion will be typhoid. Typhoid is all a bacterial infection caused by Salmonella typhi. Coming to the lesion proper, you find that there will be oval ulcers. The ulcers are oval and this is called the long axis of the ulcer. The long axis is parallel to the long axis of the bowel. And I find that the floor is what we see, base is what it rests upon. The floor is covered with necrotic debris. So necrotic floor, oval ulcers, long axis parallel to the long axis of the bowel. And this is a superb museum mounted specimen and this is the source of it, and of course it is from the net. All credits to these people, it is worth it. They require a standing ovation. I find that there are multiple oval ulcers, as I mentioned, long axis parallel to the long axis of the bowel, and these are the margins which are showing congestion, and there is a normal mucosa in between. And why are they oval? Because they are sitting exactly on the top of the Peyer's patches. It is basically a disease of the Peyer's patch, and because of that there will be an ischemia and ulceration of the overlying mucosa. That is why I get longitudinal ulcers with the long axis parallel to the long axis of the bowel, just overlying the Peyer's patch in the intestine. Again, a beautiful picture retrieved from the net. I find normal mucosa, multiple ulcers, and the black color denotes necrotic debris, and the long axis is parallel to the long axis of the bowel. And these are all supposed to be areas overlying the lymphoid follicles or the Peyer's patches. This is yet another lesion in which I am finding, see the normal mucosal folds. That means it is normal. Whereas here there is no mucosal fold. Hence it is an ulcer. What is an ulcer? An ulcer is a discontinuity in the lining epithelium caused by the gradual death of cells. And in this case I am finding that there is an ulcer. But one difference is, if this is going to be the long axis, it is perpendicular to the long axis of the bowel. Whereas in typhoid it is parallel. We'll see the differences yet again. And the why it is somewhat circumferentially placed, because it spreads along the lymphatics which are positioned that way. It spreads along the lymphatics, therefore there is necrosis throughout, and you find that the ulcer develops a horizontal configuration. Also, tuberculosis is a very chronic lesion. Because of that there will be fibrosis, and hence not only is there an ulcer, I am also finding an area of stricture in this one. So this is a classical beautiful picture of a tuberculous ulcer intestine. See what happens. There is unpasteurized milk. This is gone long back, but still, or the sputum that can be ingested when it is coughed out. These are the sources for the bacilli to the GAT. And it results in histologically a granuloma, which will develop necrosis, and the overlying mucosa, it shows ulceration. And here I am finding a well demarcated granuloma, and these are the epithelioid cells. This is the area of necrosis and lymphocytes. Surrounding the linear structures are the fibroblasts. Necrosis, it involves all the layers, and sometimes you find that the peritoneum and the regional lymph nodes can be involved. So this flow diagram, let us remember for intestinal tuberculosis. So differentiate between the two. It is a revision yet again. These are horizontal ulcers with the long axis perpendicular to the long axis of the intestine. They are shallow, and being chronic, there will be some kind of fibrosis and constriction. In this, I am finding the ulcer is having the long axis parallel to the long axis of the bowel. These again are shallow, but then there is a lot of necrotic debris. There is no fibrosis, and hence perforation is more common in typhoid. The differences already I have enumerated, and people kindly by heart it. Only thing that is missed out is you find in histology there is an erythrophagocytosis in typhoid, and also the lymph nodes are rubbery in consistency. All the other things are mentioned. In tuberculosis, there are two variants. One is called a hyperplastic tuberculosis, another is ulceroproliferative. Histology is mentioned. Please by heart. What are all the gastrointestinal lesions in tuberculosis? Intestinal, in which there can be ulcerative. We had seen that. There is one variant called hyperplastic. I'll show you the picture. And third one is a combination of both, which is called as ulcerohyperplastic. This is a well differentiated granuloma, demarcated granuloma showing giant cells. And all the pink pale cells are the epithelioid cells. These are the lymphocytes. The peritoneal mesenteric lymph nodes also can be involved. Sometimes the patient can present with anorectosigmoidal fistula. Rarely it involves the esophagus and stomach. Do not jump and say esophagus and stomach are the common sites. Intestine is always a common site for tuberculosis, secondary to the lung. This is what I had mentioned. In one, I am finding an ulcer, and look at the direction of the ulcer. It is perpendicular to the long axis of the bowel, and also there is a constriction. In this one, whereas there is a proliferation, it is looking like an ulceroproliferative lesion. Sometimes the surgeon can mistake it for a malignancy and they will do a resection. It turns out to be a hyperplastic tuberculosis. One more, the amoebic ulcer. The amoebic ulcers, usually they are pinpoint ulcers, they have got narrow orifices and they are quite superficial. The edges here are raised. These are the edges of the ulcer and they are undermined and flask shaped. What do I mean by this undermined and flask shaped? So look at this ulcer. This is a normal mucosa. There is an ulcer. It goes towards the periphery. It spreads. So it has got a flask-like shape, flask-shaped ulcer. And the organism that I find is a trophozoite. The trophozoite, you find it as an ovoid organ. It has got a nucleus, and this is the cytoplasm. And these are the cystic forms and the nucleus of the cyst, which is seen. And these all dark black areas are the RBCs. By phagocytosis, they have engulfed, and we see this. This is a beautiful picture. We must remember it, if possible, even draw. I find that there is an ulceration and then there is a spread. Why does it spread? Because the trophozoites, when they enter, there is a lot of necrosis which is caused. They need food, as a result of which they are in search of the more viable tissue and they spread towards the periphery. That is why we get a flask-shaped ulcer. And why is there lysis? because the organism is labeled so. Entamoeba histolyticum. Histolysis means it causes lysis of the tissue. And this is a typical flask-shaped ulcer. These are the various stages of it. The trophocyte we should be able to remember, and there is the nucleus with the karyosomes, and there is the cytoplasm, then the RBCs and the phagocytic vacuoles. And these are the pre-cystic and the cystic stages. This is there in your parasitology text. Kindly go back and see. This is a picture of the ulcer which I would like you people to draw. This is an end-on view. When we view it right from the top, this is the orifice and this is the boundary of the ulcer. Whereas when it is cut across, I find a narrow opening and then a flask-like configuration. The last one will be the malignant ulcer. Malignant ulcer is, what is it? You find that there is a loss of the mucosa. That itself is an ulcer. But here I am finding a cauliflower-like growth, which is proliferative. It occurs usually in the cecum. Whereas in this case, again there is a loss, but there is a constriction. This is a type of spread in the rectosigmoid region, a napkin-like constriction. So these are the ulcers of the intestine. And microscopically, I will be finding irregular glands with pseudostratification and pleomorphism. Or it can be in a sea of mucin, islands of cells in a sea of mucin, a mucin secreting adenocarcinoma. These are the two variants in a colonic carcinoma. We have already dealt with it. ZZ.